I'm Jim Wyant. I'm the program director of our neurology program here at EVMS and ODU. And I'm very pleased that I get to introduce our speaker today. Her name is Dr. Lisa Deuel, and we were residents together at Albany Medical Center. Before that, she did her undergraduate degrees at Cornell and medical school at SUNY Stony Brook. After she and I worked together at Albany Medical Center for residency and internship.
Giving the introduction. Oh, Jim.
Thank you. Yeah. After she completed her residency, she did fellowship at University of Colorado. Then she moved to Vermont, where she's become fellowship director at University of Vermont. She's been a mentor to me, a great friend and colleague, and she's a luminary of neurology and movement disorder medicine. So I'm very pleased that we get to hear from her today. No further ado.
Tell me if it's working okay. Can you hear me okay? Is that everyone in the back? I see thumbs up, or I see an up. Can I make it louder? Okay. All right, how's that? All right, then I'm not going to touch anything, but thank you, Jim, Dr. Wyant. It's so nice to be here and have the invitation to come and speak to everyone. I know you've had, I think, fairly recently, just updates on Parkinson's disease and atypical Parkinson's disorders, maybe not super recently, but this is focusing more on a little bit of background of Parkinson's, but how we make diagnoses and new advances in the diagnosis, and of course, treatment options, some of which will sound very familiar because it's been around for decades, and some of the newer treatments that we have that are really exciting in neurology and movement disorders. So we'll try to get through a lot of material, and feel free to ask questions at the end. Let's make sure. Already having an issue. Does it need to just click on it? Do you have to click on it? Sometimes clicking on that starts. All right. And just to start off, I have no disclosures related to the material. We may talk about some off-label medication used in the treatment of Parkinson's. And here's the agenda. So again, I want to start by just kind of doing a Parkinson's 101. It's hard to talk about medications if we're not at least on the same page about pathology and the diagnosis. Talk about medications that we can use early in Parkinson's, and then also as the disease advances. I always throw in something about non-medication strategies. Up in Vermont, at least, people are pretty medication averse, so we want to make sure we're focusing on what are the other things that we can do to help patients. Recognize some of the complications with these medications that we use, even the ones that have been around a long time. And then at the end, focus a little bit about which patients could benefit from advanced treatments and what those options are. So back in 1817, so over 200 years ago, James Parkinson's put out an essay on the shaking palsy. And in this, he described involuntary tremulous motion with lessened muscular power, in parts not in action, so at rest and even when supported, a propensity to bend the trunk forward, so changes in posture, and to pass from a walking to a running pace, something we call festination. That idea that your body wants to move faster than your legs and your feet can actually carry you. And the things that I highlighted here are things that even 200 years ago, he really got right about Parkinson's. But some of the other things we've learned over time, it's certainly more complicated than that, especially at the end, the senses and intellects being uninjured. We know that there's a lot of other things, a lot of non-motor symptoms that come along with Parkinson's. So again, a lot of things that he got right, but things that we're learning as time goes on that are really integral to the disease and diagnosis. So we know this is a neurodegenerative disorder affecting predominantly dopamine-producing dopaminergic neurons in the substantia nigra that you can see here. And I'm sure you've probably seen slides like this before, where that kind of dark line that I can show you over here gets much fainter in Parkinson's. So as those dopaminergic nerve cells are dying off, you lose that pigmentation that you would see. And so obviously this all being pathologic in an autopsy, you can see these changes. And the hallmark of Parkinson's, the way to make a pathologic diagnosis is the presence of Lewy bodies, which you see it in the second slide here, which are these round eosinophilic eosinophilic cells with a halo around it. And you see those in the cytoplasm of those substantia nigra cells. And you know you're in the substantia nigra because you can see that neuromelanin, that dark pigmented cells. And so, of course, we can't see this. We can't see this pathology in somebody who's alive. So when we make a diagnosis of Parkinson's, we're really basing it on clinical criteria. But if you wanted a confirmatory, a definitive diagnosis, that would be based on autopsy, and you would look for findings like this. So what's actually happening to form these Lewy bodies? Well, everybody has alpha-synuclein, and in its normal forms, you're in your monodi and tetramers. But for some reason, these proteins start to aggregate. They start to form longer fibrils, and then your Lewy bodies are that kind of clumped, abnormally folded protein. And there's a lot of theories out there as to why this happens and what instigates this that I'll mention. But ultimately, the problem here is that as this accumulates, our cells recognize this as abnormal. We try to clear out the abnormally folded alpha-synuclein, but for some reason, whether it's an issue with the actual mechanisms of doing that, this accumulates and eventually the cells die off. And so the current theory on the development of Parkinson's is that this happens in kind of a stepwise fashion. So by the time we see somebody with Parkinson's clinically, they're likely in this Braak stage 3 and beyond, meaning those Lewy bodies have traveled up towards the brainstem, they're in the deep parts of the basal ganglia, and then even spread up into the cortex. And that's where we start to see first motor symptoms and then non-motor emotional cognitive changes. The thought is that this is traveling kind of in a prion-like fashion, that when you have the buildup of Lewy bodies, that somehow triggers that abnormal folding in other cells as well. And so, again, we see this clinically once it gets to these higher stages, but ultimately the thought is that this is probably starting down lower, and it's actually traveling potentially from the gut up through the vagus nerve. So I'll come back to that in a second. But importantly, we know, of course, we're not seeing these Lewy bodies. We're not taking samples of the basal ganglia. We're not doing autopsies when a patient's alive. We're diagnosing Parkinson's based on motor symptoms. So when they've hit that point that the Lewy body pathology has spread more to the midbrain and to the basal ganglia. And so to make a diagnosis, number one, you have to have bradykinesia, that slow movement, small movement. When we ask patients to tap and open and close their hands, stomp their feet, we look at them walking at the size of their stride length. That's bradykinesia, and that has to be present. So even though we think of tremor as being synonymous with Parkinson's, some people have tremor and some people don't. And we actually subtype Parkinson's into tremor predominant forms, akinetic rigid forms who might not have tremor. So the key is they have to have bradykinesia, and then they have to have at least one of 3 other symptoms: tremor, rigidity, postural instability. And so that's what we're looking from a clinical standpoint. Supportive criteria, we like to see this look unilateral. If somebody comes in and they have a rest tremor and it looks very symmetric, or they have rigidity and it's very symmetric or axial, that makes me concerned that maybe we're dealing with some other type of Parkinson's disorder. These patients progress over time. It's neurodegenerative. But usually when I talk to patients, especially at the time of diagnosis, I talk in terms of years, even up to 1 to 2 decades that we expect somebody is going to live with Parkinson's. Almost diagnostic is a response to levodopa, and especially if you see somebody taking levodopa and they experience dyskinesia, which I'll mention later on, that's a good sign that this is regular Parkinson's. And of course, it's not a good sign that you have Parkinson's, but when you do have Parkinson's, I usually tell people you want it to be regular Parkinson's, you don't want it to be atypical. So not that that's the best news that somebody's going to hear. We certainly don't want an atypical Parkinson's disorder that might not respond to medicine or might just have more challenges. And those are these red flags. So if you're just diagnosing somebody with Parkinson's and they have really severe autonomic dysfunction, if they have really prominent cognitive changes, even changes that precede the motor symptoms, early falls, significant postural instability, eye movement abnormalities, or a rapid disease course within a couple of years, you're thinking this person looks really advanced, but I only diagnosed them a couple of years ago. These are things that would be red flags. Now, it's important to note that people with Parkinson's can have autonomic dysfunction, and usually they do, and they can and often have cognitive changes. The differentiation here is, did it happen really early in the disease course, or did this happen when they've had Parkinson's for 20 years? Very different in terms of how you think about that diagnosis. So I mentioned those 4 core motor symptoms, but there's really a lot that falls into that category of motor symptoms, and I listed it all out here, but certainly we're looking at, for bradykinesia, small movement, decrease in facial expression. Oftentimes patients will tell you that their handwriting was one of the first thing they noticed, that it starts off normal size, but then it gets smaller and smaller as I write. So those are features we look for. Those changes in posture, really stooped, kind of flexed at the waist. PISA syndrome, which sounds kind of silly, but is truly that, where they're tilted over to the side because of changes to their axial musculature. We see a lot of changes to gait over time, that shuffling, freezing, again, where the feet get stuck to the ground. They want to move. They're trying. The harder they try to move, the harder it is to move. And then festination was kind of that description in the first slide, which is, it can be really dangerous, actually. The top half of your body is moving really fast and trying to go, and your feet take these really, really slow, uncontrolled steps. And I've heard of patients kind of flying on walks, flying into ditches and flying into furniture and really hurting themselves. So a lot of changes to gait can be really problematic. Tremor, rigidity, postural reflexes. We do a pull test where we actually yank the patients backwards, which can be really unnerving. We catch them if we need to, but the goal is that they'll be able to catch themselves. And then dystonia, which is more of kind of this push and pull of different muscles fighting against each other, which can create toe curling or cramping, twisting of the limbs, in addition to rigidity. And it's also worth mentioning, I won't go into all of these specifically, but you can have a lot of non-motor symptoms go on. And as a movement disorder specialist, it gets really tricky within the parameters of a new or a follow-up visit to try to address everything that can be going on. Especially, the good example I give is if a gentleman with Parkinson's starts to tell me about urinary dysfunction, it's really hard for me to tease out, is this Parkinson's related? Could this be related to BPH? Could it be something else going on? And so the fact of the matter is Parkinson's can have a lot of other non-motor symptoms, but there could certainly be reasons that patients would have all of these issues. I tend to end up, to some degree trying to treat all of these things at different times if it's really bothering the patient, and then trying to enlist some help if I'm really struggling with constipation, getting gastroenterology involved, or urinary dysfunction, getting urology involved and whatnot. Excuse me. In terms of the timeline, I kind of pointed out, so time point 0 would be motor symptom or clinical onset when we're making that initial diagnosis. And, as a clinician, I'm going to follow patients over the next however long, which can be up to decades, with advancing disease and looking at changes in their condition over time and managing medicine. But we know that this is really going on 10 years before people notice changes to their sleep and REM sleep behavior disorder. People report a change in their sense of smell, constipation that could be going on 20 years prior. And so what this gets at, and kind of think about the Brock hypothesis with the protein changes starting kind of distally and working their way up, is that that's probably going on for 20 years. And by the time somebody has motor symptoms, they've probably lost up to 80% of their dopamine neurons. And so the goal would be, if you know that this is happening, if you could somehow identify these folks and get a biomarker for somebody that's going to develop the motor symptoms of Parkinson's, that you might be able to intervene, back here when they start developing anosmia and constipation. And then you might really be able to change the course of the disease versus waiting till we're at time point 0 when they've already lost the large majority of their dopamine neurons, and trying to do something about Lewy bodies and the remaining doesn't really have much of an impact on how things change over time. So, in terms of ancillary testing that we can do and biomarkers that we have, there's a DAT scan. This is an imaging study that's been out for a long time. It is really sensitive and specific for detecting Parkinson's, but it does not distinguish Parkinson's from atypical disorders at all. So, an abnormal scan, and you can see here that area of the basal ganglia, like we want to see that nice comma shape up here, and you're not getting that in the abnormal scan. So that's going to look abnormal, whether you have regular Parkinson's or an atypical disorder. And it's also important to point out now there's all this quantification, there's much better technology as far as these DAT scans go, but it really doesn't correlate with their disease state or how things progress over time. So I've never ordered sequential DAT scans to try to figure out, how is your Parkinson's progressing over time? That's really how we monitor things clinically. So there is good utility here. I would often use this test to help me know, is this drug-induced Parkinson's or regular Parkinson's? Drug-induced Parkinson's should have a normal scan theoretically, but it's not going to help if you're trying to figure out, is this Parkinson's or some, another related disorder. So a new test that's out and FDA approved as of 2024 is a skin biopsy test. And the current test actually detects a few different proteins in the skin sample. And obviously in Parkinson's, we're looking for alpha-synuclein. And the benefit with this is, one, you don't have to worry about other medications that the patient's taking. And it can actually help to distinguish your alpha-synucleinopathies, so Parkinson's, dementia with Lewy bodies, MSA, from non-alpha-synucleinopathies or tauopathies like corticobasal syndrome and progressive supranuclear palsy. So this is certainly nice in those instances of, is this drug-induced or not? But we have the added benefit of determining, could this be an atypical disorder with tau pathology? You would expect that to be normal. And there's another test, and we were chatting about this earlier, that's actually been available since 2021, but so far I've not used this routinely in practice, and there's new interest out there because the technology on these seed amplification assays are so much better, but you can actually detect the alpha-synuclein in CSF. And we were discussing that this is really nice for patients maybe with cognitive disorders if you're trying to figure out, do they have abnormal proteins associated with Alzheimer's or other disorders. Now you can kind of look for multiple things at the same time. If you have patients that clearly have a neurodegenerative disorder and you're trying to tease out, is this a primary Parkinson's disorder or is this a cognitive disorder, you might be able to really test, different proteins. And ultimately, there was a few things that seems like is coming out of the research is, one is, and I mentioned that this is positive in more than 90% of patients with idiopathic REM sleep behavior disorder who later convert to a neurodegenerative Parkinson's or DLB. And so ultimately the goal with all of this testing is, could you somehow detect people, again, that are going to eventually develop the disease? And if you identify them early, you might be able to do something sooner. They're also, they put out a new study recently where they're trying to look at the fluorescence patterns to distinguish Parkinson's from MSA. So right now we don't have a test that can do that. We really rely heavily on clinical examination. It's really important, from a treatment standpoint, often we say, it doesn't necessarily make a difference if we know for sure that you have Parkinson's or for sure you have MSA, because we kind of use the same medicines and we treat things the same. We use carbidopa, levodopa, and if you have orthostatic hypotension, we're going to treat that regardless. But as more personalized medicine comes out, it's really important to be able to categorize correctly. So that way, if we're trying to give somebody a treatment or study a treatment specifically for Parkinson's or specifically from MSA, and especially if we want to detect those patients before they have symptoms, having these biomarkers could be really, really important in making that distinction. So that is what we have in terms for diagnostic testing. And again, to emphasize, when I diagnose somebody with Parkinson's or a Parkinson's related disorder, it's really based on the clinical examination. But there are more and more tests that we can do that help give us kind of that supportive information or help lead us in different directions, especially if they're more complicated on certain medications. But ultimately, I tell patients, if I'm very confident that you have a Parkinsonian disorder and I get a DAT scan and that DAT scan is normal, I'm going to say that my exam is correct. I'm not going to let the test be the default here. So these are not tests that we get on everybody. They're more so used when there's some diagnostic uncertainty. But a lot of really interesting stuff on the horizon, and especially as we do more of those tests and we capture more samples, the companies are consolidating that information to help learn more about what that means going forward. So I want to focus a bit too on medication. So some of this, if you've seen patients or managed patients with Parkinson's, this should be a lot of review, because there are a lot of medications, as I said, that we use frequently. And again, a lot that we use in treatment as monotherapy, or that we can use later on. And so that's really been the standard of Parkinson's treatment over time. And then there are some new things that I'll get into at the end as well that are really exciting. But patients are sometimes really disheartened by this. But dopamine replacement with carbidopa, levodopa, it remains the gold standard of treatment. This was studied in the 1960s. It's been approved since the 70s. This is, it's been around, and patients are like, why don't you have something better? If this is from the 60s and 70s, why don't we have a better medication? And it makes the most sense. So you're missing dopamine in those substantia nigra neurons, and we're replacing that with levodopa. Obviously, we can't just give dopamine because it's too big of a molecule. It won't make it up to the brain, so we have to give the precursor levodopa. It's turned into dopamine once it crosses the blood-brain barrier. And then carbidopa is added, so it's a combination pill, carbidopa and levodopa. The carbidopa on its own does nothing. It's a dopa decarboxylase inhibitor, and it's there so that more of your levodopa crosses and gets up into the brain and becomes bioavailable. The main thing is that it reduces nausea. So if you just give somebody a ton of levodopa, they get very, very unwell. And even though it can be really helpful, they don't reap the benefit of that because they can't tolerate. So the name Sinemet, which is the name brand of the kind of the classic carbidopa levodopa we use, means without emesis or without vomiting. And as I said, it increases the bioavailability there. What is new, because it's not all negative, but this has been around a long time. We have a lot of different formulations that we can use. And so again, most patients, we're going to start on our standard tablet form of Sinemet, but there's a combination pill that also includes entacapone to try to help it last longer. And there are new capsule formulations out within the past 10 years or so to try to help it last longer. That's your Rytary and Crexont. Towards the end, I'll talk about the subcutaneous pump and a brief note on the levodopa enteral suspension, which is probably going to phase out now that we have sub-Q. But the idea here is that Sinemet is really not a long-acting medication. So a lot of patients are frustrated when I start them on this medicine and it's automatically a 3 times a day medication. Why do I have to take pills that frequently? It's really hard to remember to take it in the middle of the day. But the fact of the matter is that regular Sinemet just is not long lasting. And even when we switch them over to something like Rytary, it's still not a once a day formulation. Most of the patients I'm switching over, it says here up to 5 to 6 hours. But usually the patients I'm switching over are getting such a short duration with levodopa that they're still taking the Rytary at least 3, if not 4 times a day. But it's still better in terms of that longevity. And the only reason that I don't start people on Rytary is just usually insurance issues. So Rytary or the new one, Crexont, may be good options if the medication's wearing off early and these Sinemet doses are creeping closer and closer together. You want to switch them to something that lasts a little bit longer. If their peak dose effect is high, the Rytary usually doesn't peak as strongly. And then I'll sometimes switch people over if they really can't tolerate the Sinemet. The long-acting forms tend to be a little less potent. So that might be the reason I switch them over. I think I'm having way less trouble with insurance these days, but usually because it's newer and a more expensive medication, insurances like to see that you've tried or the patient's failed a different medication. But I really like Rytary. The Crexont is being made by the same company. So I think maybe the plan is to phase out the Rytary and use the Crexont, and I don't know the inner workings of that, but you may hear both of those names. Dopamine agonists, the list there, pramipexole, ropinirole, rotigotine, and apomorphine. They work the way that dopamine does. They kind of bypass that first part of the system and just activate dopamine receptors. There's a lot of different formulations. There's long-acting. There's a patch form, which is nice. If somebody's a little tired of taking pills, they could try the patch. And then apomorphine comes more in an infusion and injectable that I'll mention later on. But the things you've probably heard about dopamine agonists have some very specific side effects. It can have excessive daytime sleepiness and sleep attacks. which is not ideal if you have patients that are driving and working. If they're just all of a sudden going to fall asleep at the wheel, that's problematic. Impulse control disorder is huge. And a lot of patients can get that to some extent, but the stories that you hear, the ones that really stick with you, are patients that have pathologic gambling. They can have compulsive sexual behaviors and get in trouble with pornography and things like that. I've heard really horrible stories. Obviously, you want to screen for any sort of impulsive behavior ahead of time, and those are not patients that are going to get these medications. And then you want to be really open about especially having a spouse or a family member keep track of any sort of perseverative or impulsive behavior, even if it's not a bad behavior, to just keep track of it to make sure that it's not escalating. Because I think the people that have gotten in trouble with dopamine agonists is it went unchecked. We didn't know to look out for this. We didn't tell the family because it's kind of embarrassing to say, some of these things, make sure your spouse isn't doing this. And if it goes unchecked, it can be a problem. Dopamine agonists, all the dopamine medications can increase risk of hallucinations. Agonists tend to have more of that. So again, if somebody's hallucinating and they're on 3 meds, this might be one where I take this away first, because I know the likelihood is just much more that this is the culprit. So in all honesty, I don't use these a ton. They're certainly, from a benefit standpoint, they can be really helpful. There's long-acting forms. So if I choose to use a dopamine agonist, I usually go more of the long-acting route if I can. But there's certainly a role for these, especially in somebody with comorbid restless leg syndrome. A small dose of a dopamine agonist might not be a bad idea. MAOB inhibitors, there's a few of them, and they've been around for a while as well. These kind of work at the back end of the system. They keep all your dopamine around longer. They can be used as monotherapy, but the data certainly suggests that they're beneficial for symptoms, but usually not a robust improvement. So if I'm going to start somebody on rasagiline or selegiline, I usually do it because they're a once or twice a day medicine. And so if somebody's really hesitant to start, medication 3 times a day, I might pick one of these, but I haven't recently found too many people saying, this was life-changing. I felt way, way better. So I often go the carbidopa-levodopa route at this point. They tend to be really well tolerated though. And then if you add them in with levodopa, it can increase the efficacy by 20%. So they can be really helpful together. There was some data, and there'll be a slide, as we talk about disease-modifying therapies, there was hope that rasagiline might change the course of Parkinson's, but there's kind of mixed data on that. Ultimately, in one of the studies they did, the 1 milligram dose that we tend to use looked like it was helpful compared to placebo, but the 2 milligram group, which we don't use, didn't show that same benefit. So it's kind of hard to reconcile that. Why would 1 milligram be disease modifying, but 2 milligrams not? So I'm kind of in the camp of, I don't know that there's enough data to say this slows disease progression, so I don't really do that. COMT inhibitors and tacopone and opicapone are the main ones. Tolcapone was the initial one out there, but I don't see it used very often because of black box warning for liver toxicity. These medicines you would only give in somebody who's taking carbidopa, levodopa. These have no activity on their own. They just help more of that levodopa get up to the brain. So entacapone can be an option if somebody's kind of wearing off early and you want to get that medication to last another 20 or 30 minutes, you might want to add that on. Other drugs, amantadine we use pretty frequently. This was actually developed as an influenza treatment, but it's almost exclusively used in movement disorders at this point. There's a short-acting and a long-acting form. We think it increases dopamine release. The reason I like amantadine in specific patients is that it can help actually treat dyskinesia, which is not common. Most things make dyskinesia worse. And then it can help with sometimes freezing of gait and more refractory tremors. Anticholinergics were around before levodopa was developed. And they're just really prone for side effects, especially if you're dealing with a geriatric population with cognitive issues. These are really dirty medications that just tend to cause a lot more harm than good. But in a younger patient with a lot of tremor, I might give a dose of trihexyphenidyl to see if that helps. Estradiol, I've honestly never prescribed. It's an adenosine A2A receptor antagonist. And the idea is if you inhibit adenosine, it could also increase dopamine activity indirectly. I think there's enough other options out there that usually insurance is the hurdles here. So like I said, I've never actually prescribed it, but it's an option. And so again, focusing, those are all symptomatic treatments. There have been disease-modifying trials over the years. All of those medicines I just mentioned, there's really no data to suggest that they change the disease course, meaning, if we give somebody levodopa, they're going to feel better because we're treating their symptoms. If we take it away, their underlying Parkinson's is going to be the same that it would be had we not given them the medication. So it does come up often where people say, well, I don't want to start the levodopa too early because I'm worried about the kind of downstream effects and I'm going to need to take more and I'm going to have more side effects. And really the answer to that is the side effects just have to do with how long you've taken it, what dose you're taking, and giving levodopa early doesn't change what that looks like down the line. And likewise, there was some interest in, well, if we give that levodopa early, can we slow down disease progression? But there's really no benefit to that either. So I usually counsel patients that if you're having symptoms and they're bothersome to you or they're intrusive to your daily functioning, that's probably the right time to start medication, not sooner, not later. I really caution patients not to hold off. Some people really don't want to take medications. They'll hold off as long as they can. And sometimes I worry that they're doing themselves, more harm than good and getting to a place where, now they're so impaired they can't exercise, they can't be active. So trying to, strike that balance with patients is really important. I'll point out here too, and I mentioned, exercise and some of the non-medication strategies, but for, everything that we've studied to try to slow down Parkinson's so far, that's the one thing that jumps out that maybe has some sort of neuroprotective property to it. So I will say, and you'll see in the next slides, I recommend that for everyone. The data suggests you want high intensity exercise, so up to 80% of the maximum heart rate. So this really should get people sweating, get their heart rate going a little bit. So walking's good, stretching, Tai Chi, all of those are good, but not necessarily as aerobic as some of the higher intensity stuff. So that's important. So to segue then into what are, non-medication strategies that we talk about, I first point out that this really is a multidisciplinary approach. And a lot of this falls, within the purview of neurology, but also outside. And so we have a big team up in Vermont. We have social workers, psychiatry, neurology. We work closely with neurosurgery, especially if somebody is thinking about advanced treatments. We have research opportunities, PTOT, SLP. So we really try to, think about the individual patient and what they need and incorporate the right people. And primary care is hugely important on this as well, because there's so many issues that come up that we say, well, this could be Parkinson's, but it could be, aging. It could be your prostate issue. It could be a number of different things. So having that communication with primary care is hugely important to try to tag team some of these issues that come up. Very specific things that do tend to come up from patients. I always want to know about diet. There's really no Parkinson's disease diet, but I just kind of emphasize a Mediterranean diet. If it's heart healthy, it's brain healthy. And that really kind of emphasizes for them good dietary changes. People will be fearful of protein because they've read somewhere that protein interferes with levodopa absorption. And that can be true, but it doesn't mean they shouldn't eat protein. Just means, there's different ways to get around that. One is that you take your medicine on an empty stomach, and then 30 minutes later, you eat, whatever you want, including protein, and you don't have to worry as much about that absorption. You could eat a little bit of protein with every meal, so at least it's kind of spaced out and that there's going to be protein throughout the day, and we adjust medications based on your clinical response anyways. We're not measuring this, we're not doing blood samples to know what the levels are actually doing. And I read somewhere recently that they may suggest doing your protein in the evening time when you tend to be less active, and if it interferes a little bit with absorption, it's probably not as big of a deal as if during your really active time in the morning, afternoon, if you weren't getting all of that medication. We love talking about exercise. There's a lot of different types of exercise. There's Rock Steady Boxing is a Parkinson's specific boxing course. In Vermont, we have Dance for Parkinson's, Tai Chi, there's spinning classes. So as much as that aerobic exercise is really important, the fact of the matter is the best exercise is the exercise the patient's going to do routinely and enjoy. So you have to kind of meet them on that. I give them the information and say, do as much as you can and try to build that up. I really like to get my patients seeing physical therapy because they can work on a very personalized exercise regimen. But anything that they're willing to do is better than nothing. They'll often ask, and maybe this is biased because I'm coming from Vermont, but a lot of people ask about alternative therapies. And there's some data out there, a lot of studies on acupuncture, massage, chiropractic care. It's really hard to blind these type of studies. Usually, you know, if you're getting a massage or somebody's adjusting your spine. But in some of the acupuncture trials, they actually looked at sham acupuncture versus real acupuncture. The short of it is that patients like it. It's pretty low risk, all of these things. Although I will say, as a neurologist, please, if your patients are going to a chiropractor, neck down, like don't let them do any of those really aggressive neck snapping things. I've seen too many bad things happen there. But so generally speaking, safe, well-tolerated, patients like them. If you ask a patient whether they had sham acupuncture or regular acupuncture, if they feel better, they feel better. There's a huge placebo effect. It's been very well established, very well documented in Parkinson's. But when they actually look at this head-to-head, there's not great data. There's not huge studies that would say one of these is any better than the other. Again, my general take-home is if you want to try it and it seems like it works for you, that's great. There are supplements. Mucuna is one of them, so you maybe have heard of this. It comes from the velvet bean, and it actually contains, if you can extract naturally occurring levodopa from the bean itself. The problem here is that, I mean, I guess there's, as I've listed, pros and cons, and the pros is it's such a small percentage that they take out. So you can really kind of microdose it. So if somebody's having a really hard time tolerating the tablets, the Cinnamate tablets, you could potentially get away with smaller doses through the Mucuna powder that you couldn't really cut your pills that small. But the cons here are it's out of pocket. You tend to need almost 30 times the amount that you would take of Cinnamate. So you're needing higher doses to hit that same level of benefit. And then I always have that caveat of this really isn't being regulated. I couldn't recommend a specific brand. I have a hard time counseling, what's the correct dosage. So for example, here on this, this is 15% levodopa. So if you took 2 capsules, you get 120 milligrams of levodopa, which is roughly 1 capsule or 1 tablet of Cinnamate, but it's not all getting into your brain. There's no carbidopa. It's really dicey. But again, sometimes patients really want that natural option, and this could be it. There's some new interest in thiamine because there were some small retrospective studies linking low thiamine to Parkinson's. And so now some open label studies that show if you give people thiamine, that their motor and some non-motor symptoms improve. But again, we know that there's a big placebo effect and there's open label studies. So I don't say there's enough data to recommend that, but I have a lot of patients that started taking, 50 or 100 milligrams of thiamine just because. Obviously, if levels are low and they have a risk of that, I would supplement it, but we need more data. But that was something within the past couple of years that people have gotten really into. B6, people will ask, the carbidopa can actually make B6 less available, so it's worth checking, especially if they're noting neuropathy or other neurological symptoms. So again, supplement if it's low. And B12, you can see, some of the symptoms of a B12 deficiency. Well, we know that people, with Parkinson's are fatigued and they might have changes in their memory. So that can overlap a lot and you might not think of it, but it's probably worth checking B12 routinely just because we know that decreases with age and that could be something treatable, whereas, fatigue in Parkinson's and memory changes is not always necessarily treatable if it's from Parkinson's. So again, routine checks, especially if they're low, supplement, but just be cautious, especially with B6 about not overcorrecting. And other supplements that land on this table of neuroprotective that have been studied, coenzyme Q10, creatine. They've done really big studies of up to 2,400 milligrams of CoQ10 and ultimately stopped those trials because there was no evidence that that slowed disease progression. So some people would ask, is it worthwhile taking CoQ10? Again, probably not harmful, but the data in Parkinson's, unfortunately, is that this doesn't slow disease progression. And lastly, and I didn't check the the rules down here, but in Vermont, it's cannabis is available. I trained in Colorado where it was very available. So a lot of patients would come in asking, and frankly, a lot of elderly patients, especially in Colorado, would come in already having tried it because their grandchild got it for them. There's a lot of data out there. And again, in open label studies and small trials, there's suggestion that it's helpful for motor and non-motor symptoms, that it can lessen dyskinesia. There's really no large trials. When I was in Colorado, they were doing a randomized trial that I think they ultimately ended up enrolling 40 to 50 patients in. It was jumping through hoops to do a trial with all kind of the government regulations, with cannabis not being approved everywhere, even though it was approved in Colorado. So it's really hard to study this. And ultimately, they showed that if you use products low in THC, that's probably safe. But the data ultimately that they looked at didn't seem to show that it changed much about the Parkinson's itself. So my take home for patients that ask me about this is, it may be helpful, and there does seem to be benefit for things like anxiety and sleep. And we know that if you're feeling anxious, you're going to shake more and your Parkinson's is probably worse. So it could be helpful. I'm not able to give somebody specific guidance on what dose they should take and how frequently. But the main take home is that especially elderly patients should not get products high in THC. So if you're going to try this, you want a low or no THC. So that's, again, kind of rapid fire summary of medications we have available, non-medication strategies. Usually this is, all things considered, pretty smooth sailing early on. The medications work really well. And in fact, we expect carbidopa, levodopa to continue to work over time. And a lot of my patients will ask, like, what happens when it stops working? And it never really stops working. It's just less effective over time. And I have some slides and kind of charts to show you what I mean by that. So early on, you take your medicine at the X's. These are 3 times a day, and you get this kind of kick into the medicine, and you kind of sit nicely in that green area of the medicine's on and working. I'm not having side effects. And a lot of people early on will say, I can't really tell that I've taken my medication. I don't feel it kick in. I don't feel it wear off. And so this is usually pretty good dosing for a period of time. I still try to emphasize, taking it on a routine, but it's probably less important at that point unless they feel worse. But what happens over time is that, if you stick with that, say, 6-hour dosing, that the medication just doesn't quite last as long. And they're dipping down into that off area where they're just not feeling as good. They're shaky, stiffer, slower. And then if you redose the medication at that point, as you're seeing kind of right here, it takes some time. It takes a few minutes for the medication to start to kick in. So you can end up with, 30 to 60 minutes of just not feeling as good between doses. And so that's what what we describe as wearing off. And so these can be motor symptoms or non-motor symptoms. Sometimes people don't really notice the shakiness or stiffness, but they feel really anxious. They just don't feel right. And then they take their next dose and they feel better. And so for those patients, we might move the doses closer together. We might increase the doses and then it lasts a little bit longer. We can add in other medications that, work synergistically with the levodopa, or as I mentioned before, switching to long-acting medicine. So ultimately, this would show now the patient's taking it, let's say, every 4 to 5 hours, and they're taking 4 doses. And that helps because they're redosing before they drop into that kind of red zone. But then again, as the dose goes up and you're taking it more frequently, and maybe you've added in other medications like entacapone, which is going to boost the peak of the medication, the other issue that comes up over time is these peak dose side effects. And so certainly the more you take at once, the more likely nausea and dizziness or lightheadedness and drops in blood pressure. Those are certainly more likely to happen at the peaks. At the peak of the medicine, this is where you tend to see dyskinesia. So that on with side effects oftentimes refers to when you have dyskinesia. The key is that the medicine is still on and working. So oftentimes when people have dyskinesia, they feel good, they feel loose, but they have these kind of dance-like movements. If you've seen Michael J. Fox, he's kind of always wiggling and moving. And the important thing to know there, if we didn't give somebody medication, they would never get dyskinesia. It's a relationship between the medication and your dopamine receptors. So it's not an inherent symptom of the Parkinson's, but a relationship to the medication. If they're mild, most people don't mind them. And sometimes they're more bothersome to the person looking at them. Like they just look a little restless and you feel like you have to do something about it. But my number one question is always, how bothersome is this to you? And if it's not bothersome, we leave well enough alone. It correlates to the medicine being on and working. And we'd rather that the medicine was, doing what we need it to do for tremor and mobility. If it was bothersome, you could lower the dose at the expense of potentially worsening the Parkinson's symptoms. This is where I might use amantadine in the right patient. Amantadine is also really prone to hallucinations, anticholinergic side effects. It can worsen constipation. So there's a lot of potential side effects with amantadine. So it's not for everybody, but in the right person, this is actually one medicine. Everything else is potentially going to make the dyskinesia worse, but amantadine could treat it. Smaller doses more frequently, so you don't hit those peaks as much. And then this is my segue into the last portion here, which is what are our advanced treatment options? What do you do with patients when, again, medication still works, but it's just not working as effectively, and we're prone to some of these ups and downs and motor fluctuations, dyskinesia. So what do you do with those patients when you've kind of exhausted medication? Again, these patients are not off medication. They're usually still taking the medicine, but I've had patients that, I've tried to switch them to these other treatments because they're taking their levodopa every 2 hours. And it just really becomes unsustainable. At that point, you're so linked to the time of your medication. Plus, if you're having that protein effect where the protein you take in with a meal really dramatically impacts your medication absorption, well, how do you balance that if you're also taking medication every 2 hours? So when do I consider these advanced treatments? So again, the key is the medicine is still helpful when it's on and working, but the time between doses is shorter and shorter. So patients are complaining more of that off time. When they are on, they're having more on time with dyskinesia. And again, those dyskinesia are probably more severe and more bothersome at that point. Another time to consider this is if they respond to medicine, but you're really limited in the dosing because of some side effects. And I've had patients that just really can't tolerate much levodopa because it makes them so sick to their stomach no matter what we do. So those might be patients that you consider these treatments for sooner. And then the one caveat to all of this is we might consider a treatment earlier if all of their symptoms respond to medicine, the bradykinesia, rigidity, shuffling respond to medicine, but they have medication refractory tremor. Those patients actually tend to do really well with deep brain stimulation. So you might consider that sooner in that population. So right now available, and these are in order of approval, not in order of invasiveness, but how long they've been available. And so first is deep brain stimulation, and hopefully you're all at least somewhat familiar with DBS. What we do here, and this has been around for essential tremor since the 1990s, approved for Parkinson shortly thereafter. The idea here is we're implanting electrodes into the deep areas of the brain, either into the STN or the globus pallidus, to modulate brain circuitry in those regions and try to lessen what I'll describe to you as these kind of bad signals that are happening in Parkinson's. The appropriate candidate here, as I mentioned, is somebody that's probably had Parkinson's for at least 5 years. The key here is you want to make sure that they're not going to evolve into more of an atypical disorder. Those patients do not do well and are not candidates for surgery. So if early on in the first couple of years, it looks like Parkinson's, but maybe there's some concerning features, that would be a really bad person to put a DBS in, because if it turns out they have dementia with Lewy bodies, as you'll see here, we want patients with minimal cognitive impairment, minimal balance impairment, because we can make those things pretty dramatically worse with a brain surgery. This is what it actually looks like on X-ray. So those electrodes go pretty deep down into the brain there, and then they pass out, and it kind of coils here on the surface. And then the the cords run down to what looks like kind of a pacemaker on the chest, and that's where the battery sits and where we connect to do our programming. I mentioned just very briefly, right now for Parkinson's, there's two main targets. All of them treat the Parkinson's symptoms, or sorry, both of them do. Both of them treat tremor, but there might be a reason we pick one more than the other. If somebody does have a lot of dyskinesia, we might pick globus pallidus. That's a larger nucleus, so it's a little bit easier to target. And from a surgical standpoint, you're less likely to be off. But the main thing, and we actually, at my institution, typically do STN because you can actually reduce medication quite significantly. Most patients are able to cut back on medication by at least 50%. So that would be a reason to pick STN. But either way, whether you pick STN versus GPI, they both improve on time without dyskinesia and they lessen off time. And the nice thing, so right now, there's 3 main manufacturers, Medtronic, Abbott, and Boston Scientific. And this has really helped with a lot of upgrades over time. There's rechargeable batteries. They last longer. The device is more compact. As a programmer, Abbott has a capability where we can do remote programming for my patients that live hours away. But the new feature is this adaptive programming. It's kind of closed loop circuitry. So we set the parameters here, but essentially the electrode both records and gives stimulation. So it captures these LFPs, these local field potentials, that when they're in the beta range signify worsening Parkinson's symptoms. And if your device is set to capture this, it recognizes that, okay, you have more of these beta bands, you're probably having worsening symptoms, say the medication that they're taking is wearing off. It cues an increase in the stimulation here. And so in this snippet, you're seeing, all these beta bands, your stimulation increases automatically within the parameters we set, and then those beta bands disappear. And so this is really new, approved within the past year or so, and is really going to change the way we do DBS for Parkinson's patients. The Deuel pump, I think this is going to be phased out, but it's worth a quick mention. This is kind of a GJ tube. It's not a feeding tube. Nothing else goes in here. It's just a continuous delivery of levodopa. So the same thing that you take in pill form, we just calculate how much that would be in a continuous infusion. It's an option for patients that are just tired of taking pills and they want something that's a little more consistent, but it doesn't really get around that interaction with food because it's still absorbing through the gut. But the idea here is that you would just get a smoother course of medication. And this has been around for a while. Focused ultrasound is a newer procedure, again, approved first in essential tremor, but available for Parkinson's, both Parkinson's tremor as well as Parkinson's motor symptoms. And we use that high intensity, high frequency ultrasound to create a little scar in the same areas we target for DBS. And so after the procedure on this heat map, you see that area where you've created basically a little lesion there that would interfere with those bad signals. And on MRIs, you can see that change over time. My main concern with this is just, it's irreversible, but 2, it's just not been around long enough to know what does this look like over time, especially for somebody with Parkinson's, which is going to progress over time. What does that mean in 5 years from now, 10 years from now? Are we having to do this procedure again? Are you putting a DBS electrode in this patient after they get the focused ultrasound? Because you could do that. So I just feel like we don't have enough data there, but it is something that's growing in popularity, mainly because it's less invasive. So nothing's implanted, no incisions are made. You do have to shave the patient's entire head, which is actually a deal breaker for a lot of people. But otherwise, it's a lot less invasive, and people are looking for, again, something in between, which isn't quite brain surgery. Last couple of slides here. These are really new. This phospholevodopa subcutaneous pump was approved about a year ago. And same idea as that Duopa pump, but instead of needing that GJ tube placed, this is something that patients do at home, usually with a care partner. Kind of akin to an insulin pump, where they're using that plunger device to place a subcutaneous cannula, and then that's delivering levodopa continuously around the course of the day. It can run 24/7, and most of my patients, I have one patient on it, one of my patients are doing this 24/7 because they're up and down a lot during the night too, and they're consistently getting medication. The benefit here is you don't get that interference with food. It's going right to the subcutaneous tissue, absorbed into the bloodstream. You may get some protein interaction crossing the blood-brain barrier, but nothing to the extent you would get with with the GI tract. You can give bolus doses, but ultimately this takes the place of oral levodopa. So I've had some patients not care for it, so tried it out and didn't like it for reasons I'll show you, but one patient on it and swears by it and wants to be the spokesperson for it. Even though, again, the biggest risk of this is skin infection, cellulitis, nodules. He's been hospitalized on IV antibiotics for this, and I expect him to come in every time telling me he doesn't want it anymore, and he swears by it because it's made these huge peaks up and down so much better. It's made him able to function at such a huge change that for him it's worth that trade-off. And in the study, that's exactly what we're looking at here is you see that up and down of oral administration of levodopa versus that smoother course, improving on time. And then last one, and I do not have experience with this just yet. This is newly out in February 2025, but it's an apomorphine subcutaneous pump. This would not take the place of your levodopa, but could be something that you give for more continuous or bolus dosing as an adjunct therapy that you would use during your waking hours. Both of those, I'll say, you change the site for this pump every 24 hours. For the Vyalev pump, it's up to 72 hours. And again, this subcutaneous apomorphine pump improved on time and lessened off time. But this is kind of what we're dealing. You can kind of see in this some of that nodular appearance, and those don't always go away. I have some patients, especially thinner patients, that tried the pump for a month and she can still feel the nodules like 6 months later. So it's certainly a device-specific side effect. So this is just kind of comparing all of those. Like I said, I went in order of when they've been approved, not invasiveness, and there's pluses and minuses to everything. DBS, it works wonders for people and really makes a difference, but some people are just not interested in the risks associated with that. So it is nice that we have these other options that are a little bit more than medication, but not as invasive as that procedure. I won't read through all of this for you, but it's kind of there as a comparison. And with a minute to spare, thank you so much. I really appreciate, like I said, I appreciate the opportunity to come and speak to you all about Parkinson's treatments, and I'm happy to field any questions. I know that was kind of a deep dive and a lot of information, but yeah, happy to.
Thank you. Great presentation. You have the same problem I have when I talk about Parkinson's. So many interesting things, you always run out of time. 2 questions. One is the MIND diet. The second one is veterans. The MIND diet has been reported to delay onset and slow progression of Parkinson's disease, more so than the Mediterranean diet. So that's question 1. Number 2, you're in the hotspot for veterans in the United States. And as you well know, veterans have a disproportionate risk for Parkinson's disease, TBI, Agent Orange, and so on. Could you comment on MIND diet and on veterans?
Sure. I'll escape that a little bit. And I don't know too much about the MIND diet in comparison, but I think if I focus on one thing that you said, which is if you implement these things early, or if you could identify people early or before they had motor symptoms to implement a diet, a very specific diet that was neuroprotective, that would be the goal. I can't answer the specifics of that, but I'll certainly look at the differences between the MIND diet and like a Mediterranean diet. But the idea of a lot of these diets are, of course, heart healthy, brain healthy, and then neuroprotective, antioxidant, things like that. So I don't know the specifics of it, but I want to emphasize that idea of if we know who's going to get Parkinson's, these are definitely the people to implement these strategies with. Interestingly, where I'm practicing at University of Vermont, we don't have an affiliated VA. The White River Junction VA is the Vermont VA, and it's actually affiliated with Dartmouth because it's just across the river. So it was one of my favorite things in fellowship and even in Albany in residency is we did a lot of work at the VA, but I don't have that experience as much anymore. And that's not to say I don't see VA patients and veterans. A huge risk factor, we think, is Agent Orange exposure. People get service connected for that. But there's a whole ton of other exposures, environmental exposures, that have come up as concerning. We just don't have that longitudinal data to know what the risk of Parkinson's looked like. But there's, I will say, and again, didn't have time to talk about it today, but there's a huge interest in environmental exposures as that second hit in a two-hit, genetic plus environment, increasing your risk of Parkinson's. So clearly veterans are a vulnerable population who've had a lot of exposures that are really hard to quantify. And even folks who were exposed to Agent Orange, when I ask my patients about that, it's hard to know how much they were exposed. Some people were right in the midst of it. Some say I was in the right place at the right time, so I was probably exposed. So it's really hard to know what that means. But trying to balance out, that being a vulnerable population, it's also a good population to study. Again, if we're trying to look for biomarkers and we're trying to identify who's going to develop Parkinson's, that is a good population to emphasize on without, I guess, I don't want to say coercing, but it can be a dicey population to study just because of the vulnerability. But I might not have answered your questions exactly, but to the best of my ability. But no, I think those are great thoughts.
Thank you for your talk. I know we don't have much time. What about GLP agonists to prevent Parkinson's?
I've definitely seen interest in that, and it kind of fizzled a little bit, and I'm not quite sure. And I suspect it had something to do with the pandemic. There's a lot of research projects I feel like are getting started up now that has faded. Again, going off track a little bit, but stem cells being one of them. There was a lot of interest in stem cells. The pandemic hit, research slowed down, and we're only starting to get that started again. So I would imagine, especially with how available they are, that will pop up again. I know there have been trials with exenatide as potentially slowing disease progression. I just don't think there have been any big studies, and I don't know actively. I know we're not running any of those, but I don't know if they're active. But it was certainly an area of interest a few years back that maybe stalled out a little bit. But with how available they are and how much they're being prescribed, I would be very shocked if we don't see more info about that soon.
Other questions? Well, thank you. Thank you very much.
Thank you.